Hello, everyone, and welcome to our continued critical discussion on antimicrobial stewardship at the Leading Health Systems Network. My name is Mary Helen Pombo, and I'm a fellow at the Centre for Health Policy at Imperial College London and lead on the Leading Health Systems Network program. Today, I'm joined by our guest speaker, Dr. Fabiana Lorencatto, research lead at the Centre for Behaviour Change at University College London. It's great to have you with us, Dr. Lorencatto.
Thank you so much for inviting me.
Today we'll be dedicating our session to applying behavioral science to design hospital antimicrobial stewardship programs. The topic of behavioral change has been a recurrent one throughout our webinar series this year, coming up time and time again in our talks on nurses' participation, governance and organizational management, and the Q&A sessions that followed. The usual questions have been, how do we change the behavior of prescribers? How do we get nurses more committed to the AMS agenda? In certain settings, that's been coupled by the familiar question, how do you get prescribing physicians to in turn be more receptive to the involvement of nurses in therapy decision-making? Many participants in our series have made it clear that the success of any AMS program is interlinked to a complex web of behavioral norms. So in many ways, this dedicated session is well overdue. To briefly provide some context on the network, the LHSN is a collaborative network of healthcare leaders and organizations working to improve health service delivery. Based here at Imperial College London and working in partnership with the World Innovation Summit for Health. With this slide, I'll just highlight that we are on social media and we invite you to join today's conversation online via LinkedIn and Twitter. Our handle and hashtag for this event are available on the presentation. On that note, I'll highlight that we'll have some time for questions and answers at the end of the session. However, please feel free to send us your questions and comments during the presentation. Now it's with pleasure that I introduce our featured guest speaker, that is, again, Dr. Fabiana Lorencatto, research lead at the Centre for Behaviour Change at University College London. She comes to us as a health psychologist, having worked on a wide range of multidisciplinary projects with practitioners and policymakers. She manages a number of grants related to infection prevention control and antimicrobial stewardship. Dr. Lorencatto is the behavioral science lead on two multidisciplinary research programs funded by the UK Economic and Social Research Council, both of which aim to apply behavioral change theory to one, exploring a range of behavior-related sociocultural and environmental factors that influence antimicrobial use in different care settings, and second, feeding that information for the design and success of stewardship programs. Dr. Lorencatto completed a Master's in Science in Health Psychology at King's College London and a PhD in Clinical, Educational, and Health Psychology at UCL. Now, without further ado, I'll turn our audience over to you, Dr. Lorencatto. Thank you for joining us.
Great. Thank you very much, Mary Helen, for that comprehensive introduction. Saves me having to introduce myself. But good morning, everyone, or afternoon, depending on where you are. Thank you so much for the opportunity to speak to you today. As Mary Helen said, I'm Fabiana Lorencatto. I'm the research lead at the Centre for Behaviour Change. And just very briefly, just a bit of background as to what is the UCL Centre for Behaviour Change. We were established about 5 years ago with the aim of harnessing the breadth and depth of academic expertise across different disciplines in behaviour change, and to try to help translate that evidence base and theory into policy and practice. We have quite a diverse portfolio of different teaching, research, training, and consultancy activities on a range of different behaviour change topics, everything from self-management and chronic illness to cybersecurity. But as Mary Helen alluded to, infection prevention control, and in particular antimicrobial stewardship, is a real area of specific focus for us right now. And we are working on applying behavioral theory and evidence to design antimicrobial stewardship across care settings, including hospitals. And that's what I want to talk to you all about today. In today's talk, I want to briefly talk about why we should think about behavior change when it comes to antimicrobial stewardship. Then I want to briefly talk about what's the state of the current art of behavior change and antimicrobial stewardship, and perhaps some of the limitations in how behavior change has been considered thus far. Before moving on to outline one behavioral science approach to designing interventions to improve the quality of healthcare, and I'm going to introduce the steps of this approach and different theory and evidence-based frameworks that go along with this. and then briefly give an example of how we and others have been applying this to design interventions to improve antimicrobial stewardship. So without further ado, why behavior change? Hopefully to this audience, I don't need to highlight the very real public health threat that is antimicrobial resistance. I'm assuming everyone here is aware of antimicrobial resistance and the importance of trying to tackle it. And this is widely discussed in the literature, but also in the media with sensational headlines such as this. And often they're accompanied by statistics such as the number of antibiotics that are prescribed that are perhaps unnecessarily prescribed or inappropriately prescribed. However, we know that overprescribing of antibiotics is one key factor contributing to AMR. As this World Health Organization infographic that some of you may have seen before highlights, there's lots of other factors that are contributing to AMR. Everything from the use of antibiotics in agriculture to the lack of development of new antibiotics, use of diagnostics, poor infection control in hospitals and clinics, as well as patient factors such as hygiene, sanitation, not adhering to medication, so not finishing the course of antibiotics when they are prescribed, or perhaps seeking antibiotics when they don't need them for symptoms that cannot be treated with antibiotics. But what I'm trying to get at with this slide is that what is it that all these different factors have in common? Well, quite simply, they are all forms of human behavior. So all these different causes of AMR are actually behaviors. And this is also reflected in policy. So if we take the UK antimicrobial resistance strategy as an example and look at some of the first three key areas, priority areas to tackle, which are highlighted in this policy, it is things such as improving hygiene practices to stop the spread of infectious diseases, reducing the overuse or false prescription of antimicrobial drugs, and increasing adherence to evidence-based guidelines. Again, what do these things have in common? They are all forms of behavior. So what I really want to start this webinar with is the point that tackling the complex issue of AMR depends on the complex challenge of changing human behavior, everything from preventing infections happening in the first place to then managing them and ensuring antibiotics are used appropriately. And this doesn't just require the behavior change at the individual level, but it requires behavior change at different levels of the system and for a wide range of individuals, everyone from patients to groups of healthcare professionals to hospitals and policymakers. So behavior change is key to tackling AMR, but to what extent is it considered or addressed when it comes to the design of antimicrobial stewardship? And now shifting gears to specifically look at the hospital context. So in recent years, there's been a number of reviews that have aimed to synthesize the state of the art for behavior change in hospital antimicrobial stewardship. And here's just two examples published last year in 2017. So a Cochrane review of interventions to improve antimicrobial prescribing in hospitals, as well as a review of the evidence base around behavior change interventions specifically. So the first thing to highlight from these reviews is that there's actually been a lot of behavior change research around antimicrobial stewardship in hospitals. Over 200 trials trying to test the effectiveness of one or more different types of behavioral interventions. So everything from educating clinicians to giving them reminders, feedback on their practice, using persuasive strategies to try to change their practice, etc. Now, the key question these reviews aim to answer is, well, do these interventions work? Which is a very important fundamental question to answer, and is often the starting point is, how effective are these interventions? In short, yes, they do. The general evidence suggests that almost any of these intervention strategies generally do have some evidence of being effective across a range of primary and secondary outcomes. So everything from increasing the appropriate use of antibiotics and compliance with antimicrobial policies and guidelines to reducing some secondary outcomes such as length of hospital admissions, duration of treatment, costs, with no associated increases in mortality or other negative consequences. So great, these interventions work. However, there's always a but, when you dig a little deeper, what you find is that the same intervention can have hugely variable effects. So sometimes they work really well and other times they don't work as well. So taking educational materials as an example, in the Cochrane review of hospital stewardship interventions, if you look, they report that this specific intervention strategy sometimes worked to improve antimicrobial use by 3%, and other times it worked to improve it by 50%, so almost 17 times more effective. That's quite a wide range in effectiveness. Which begs the question, why? If the strategy works, why are we seeing it work really well sometimes and at other times working perhaps still working, but not to the same extent. And unfortunately, it's unclear. We don't really know what makes one intervention more effective than another in different settings and contexts. So the key and answer question around behavior change and antimicrobial stewardship is not whether or not these interventions work, but rather how, for whom, where, and when. And how can we select interventions that might work best in specific settings? Now, unfortunately, or fortunately, depending on how you see it, this issue is not unique to antimicrobial stewardship. I'm involved in quite a lot of different systematic reviews that aim to synthesize evidence on the effectiveness of different types of behavioral interventions. And what we almost always find is that interventions to change behavior of healthcare professionals and improve the quality of care overall are effective. They have modest, albeit worthwhile, effects on clinical practice. But again, huge variability with interventions sometimes working really well and other times not so well. So trying to disentangle these effects and work backwards to find, well, what's making it more effective in some settings and not others is actually quite difficult to answer. And in part, that's because of limitations in how we traditionally design interventions to improve clinical practice. So the traditional approach to designing behavior change interventions is often one of having a problem and rushing to solution. You know, the reality of clinical practice is we often we're rushed, we don't have time to work through things systematically, but that means that we often rush to just try something, to just put something into practice to try to improve the problem we are trying to address. And that means that we often design interventions on what's been called the Isligiac principle of intervention design, which was a term coined by Professor Martin Eckl, an implementation professor here in the UK, which simply stands for it seemed like a good idea at the time. By that I mean is that we don't have a rationale for why we chose a specific intervention strategy. Instead, we all do behavior. We're all humans, right? So we all know what needs to change. The design interventions based on hunches, gut instincts, or common sense as to what we think in our implicit model and theory of what's driving behavior needs to change. Sometimes those assumptions are right, but sometimes perhaps they're not right. Almost always they reflect the perhaps naive assumption that it's just a knowledge issue. If we just educate people or give them a guideline, they will change. And although education is absolutely key, is absolutely critical, as we'll see later in this talk, we know that the influences on behavior are much more wide-ranging than just educational issues or knowledge deficits. There's many more social-cultural and environmental drivers on behavior that also need to be considered. Or instead, the assumption that, well, that intervention strategy works elsewhere to change a different behavior, so surely it will also work to change antimicrobial stewardship. I've sometimes seen collaborators come up and say, well, we know, for instance, smoking cessation was really effective when it used these interventions, so surely we can use that to try to improve hand hygiene in hospitals as well and at a systems level. Smoking and hand hygiene are very different behaviors, so although an intervention strategy might be effective for implementing change on a system level in that context, it won't necessarily translate to a different behavior in a different context. So why is this a problem? Well, if we don't have a rationale for why we chose an intervention strategy and we haven't designed it systematically and articulated that rationale, it becomes quite difficult to interpret the intervention effect. So did we actually target the right thing, the right influence on the behavior? What was the rationale for choosing that? Or was there perhaps a mismatch? If your intervention works, in the Isligiac principle, that's great. Sometimes it can work, but it makes it very hard, let's say, if I wanted to replicate your intervention, to put that into practice. If I don't know why you chose that intervention strategy, what specifically was in your intervention, replication becomes quite difficult. But also, more importantly, I think, it makes it much harder to learn from intervention failures, as it were, quite a negative term. But if our intervention didn't work and we don't know why we chose that strategy, we can't work backwards to understand, well, did it not work because I targeted the wrong thing? Was education and knowledge really the gap, or was there something else? So what we end up with is essentially this black box phenomenon, which is often referred to as complex behavior change interventions. We just don't know what's in them, we don't know why they work, and how we can optimize them. So instead, our discipline tends to advocate for a more systematic or different approach to designing behavior change interventions to try to overcome this Isligiac phenomenon and black box effect. So our starting point for introducing this is often this analogy of going to see your doctor, your primary care physician or GP. You would hope, although we know this is not always the case, that if you presented with your GP with some physical symptoms, because you're feeling unwell, that they would first examine you, examine the problem, examine your symptoms, use the results of their examination to make a formal formulation or diagnosis as to what your symptoms are, and then use those symptoms to select the treatment that's most likely to be appropriate and effective in treating your symptoms. So matching the choice of treatment to the symptoms of your condition. Sounds straightforward, but why don't we approach behavior change intervention design in the same way? Rather than rushing to intervention, why don't we stop, do what we call a behavioral diagnosis to understand what are the factors driving behavior, what are the barriers and facilitators to current behavior, and then using that identification of, if we see barriers and facilitators perhaps as symptoms, why don't we use those identified symptoms in our behavioral diagnosis to inform our choice of behavioral intervention? Sounds straightforward, right? However, if we look at, again, going back to antimicrobial stewardship in hospitals, and there's been, again, reviews that have aimed to look at the extent to which the design of antimicrobial stewardship programs takes into account barriers and enablers to behavior, we find that often the state of the art in antimicrobial stewardship research and practice in hospitals is actually one of a legit approach. So very few antimicrobial stewardship interventions have an explicit rationale, report the rationale for why they chose that intervention strategy. Instead, they say, well, we did an educational campaign without explaining why they chose to do that. They don't take into account or explore the behavioral and social influences on antimicrobial use and use that to inform their choice of intervention strategy. They are often not designed on the basis of behavioral theory, and they very rarely incorporate behavior change techniques, which was a finding from the Cochrane review. So we're trying to design programs to change behavior, but we're not accounting for behavior or incorporating behavior change techniques. So again, a key conclusion from the reviews and the state of the art is that we don't need any more trials to try to answer the question of does an antimicrobial stewardship program to change behavior work or not? What we need is more investment into developing and testing planned behavioral change interventions where we first assess the likely barriers and facilitators to the behavior of interest and use that to inform the choice and development of intervention. Addressing this gap and moving forward requires bringing together different stakeholders from different disciplines to design and deliver antimicrobial stewardship programs. And in particular, there's been a call for more multidisciplinary approaches to antimicrobial stewardship that involve the behavioral and social sciences. So there's a whole host of different disciplines that fall under this umbrella of behavioral and social science that are specifically dedicated to scientifically studying human behavior in a systematic way. So everything from psychology, which is a discipline I come from, to sociology, anthropology, geography, law, etc. Now, this is where I usually pause and give a health warning. I think there's sometimes a misconception with behavioral and social science that we can offer universal truths and magic bullets with the solutions that can change behavior and that will work every time. But that's not the principle we are trying to encourage, and we will not wish to encourage that. Instead, what these disciplines aim to offer is theories, frameworks, and methods that can enable a more contextualized understanding of what drives behavior to design more targeted and tailored interventions that are more likely to be effective. So we're not aiming to identify universal truth, but actually facilitate a more in-depth needs assessment and specific tailored intervention development that takes into account behavior in context. And today I'm going to talk through just one approach. There are many different frameworks and approaches across the different disciplines in behavioral science that use intervention design, and all these different frameworks have their different strengths and weaknesses. But I'm going to talk about one recently developed approach within our group that is called the behavior change wheel approach, and it has been increasingly applied to design interventions and understand behaviors around antimicrobial stewardship. And what the behavior change wheel approach offers is an interrelated set of theory and evidence-based behavioral science frameworks and principles, which aim to offer a theoretical basis for understanding what drives behavior and linking barriers and facilitators to the selection of intervention strategies. They aim to be practical tools that offer that step-by-step, transparent, systematic approaches to intervention design that can help guide decision-making for policy makers, researchers, and practitioners who want to design interventions to change behavior. And I'm going to talk us through the different steps and some of the different frameworks associated at each step and how this has been applied to antimicrobial stewardship. So the first step is being very precise about what behavior you're trying to change and defining the problem in behavioral terms. The second step is conducting that all-important behavioral diagnosis, as I just mentioned, so understanding behavior in context to identify barriers and enablers to change. Before using the findings from your behavioral diagnosis to consider the broad range of intervention strategies and match your choice of intervention to what you found in your behavioral diagnosis. So starting with what behavior you are trying to change. Sounds obvious again, but this is such a crucial step in the process, which is often overlooked. So the starting point for any intervention design should first be defining your problem in behavioral terms. More often than not, we jump to think about the outcome we are trying to change, but something such as reducing infection rates or improving infection control is not actually a behavior. It's actually the product or outcome of lots of different discrete behaviors, such as things as hand washing, effective use of protective clothing, cleaning surfaces, maintaining appropriate isolation, prescribing of antibiotics. And all these different behaviors interact. They form a system of behaviors that can either facilitate or compete with one another. So for instance, if we take nurses' hand hygiene behavior, that's one person's behavior, which is actually influenced by the behavior of perhaps senior doctors who might model or demonstrate hand hygiene behavior and create a culture or norm of hand hygiene. Patients' behavior in terms of asking and demanding hand hygiene from their healthcare professional, as well as the behavior of domestic staff in hospitals who need to ensure the availability of gel in the dispensers. These lots of different actors and different behaviors interacting to form a system which will contribute to the outcome that we want to change. So a crucial starting point in intervention design is to map out that systems of behavior to identify where best to intervene and how. Now, this is absolutely crucial for antimicrobial stewardship, which is arguably a highly complex set of different behaviors. So it involves multiple actions with multiple behaviors, such as use of diagnostics, in everything from ordering the diagnostics to interpreting the diagnostics to using that to inform decision-making around antimicrobial use, so everything from the drug choice, route, dose, duration, ensuring it's administered in a timely fashion, recording this decision in the patient notes, communicating that to your colleagues, and within a certain time frame, reviewing the prescription, deciding whether to switch, stop, or continue. These are all different behaviors, and different things will influence these different behaviors. Add to that the fact that antimicrobial stewardship is an interprofessional effort. There's multiple behaviors performed by multiple actors, everything from senior to junior physicians, nurses, pharmacists, etc. Across multiple settings, so different wards, hospitals, as well as everything from secondary care to primary care, care homes, pharmacies, and also different time points in the patient care continuum. So highly complex behavior that we need to first break down to identify, well, yes, targeting antimicrobial use is a behavior, but which specific behavior and whose specific behavior are we interested in? And it's really important that we design interventions that are targeting a behavior that's specified as precisely as possible. So being more physically active or reducing antibiotic prescribing in hospitals are behaviors, but they're not sufficiently specific. So let's say my New Year's resolution is to be more physically active. I'm much more likely to succeed in being more physically active if I define that behavior and that goal in a more specific way. So first of all, because it can make it more targeted when I design an intervention, and because different behaviors have different influences, I said. So, if we want to understand the behavior in context, we're more likely to have a more informative behavioral diagnosis if we say, well, I don't just want to understand antibiotic prescribing, I want to specifically understand antibiotic prescribing in surgery by surgeons, etc. And if we do a more focused behavioral diagnosis, we can design more focused interventions, and also more specific behaviors are easier to measure and give us a more precise metric for evaluating the success of an intervention. So start your intervention by thinking about who needs to do what differently, where and when, and how often, and to whom. So for example, if we were to take the reducing antibiotic prescribing in hospitals and try to make that more specific in terms of a target behavior, we could see it as surgeons, the who, on the cardiac surgery ward, the where, stopping antibiotics, the what, within 24 hours after surgery, when, for coronary artery bypass graft patients. This is an example actually from the literature, one of the studies included in the Cochrane Review, which I think is a really specific, nice, focused description of what that intervention was targeting. So having defined your specific behavior that you want to change, that fundamental starting principle, the key step, I think, in this whole process is the second step of doing a behavioral diagnosis to understand behavior and context and identify what will it take to bring about the desired change. So the key questions we're trying to answer here are, why are behaviors as they are? This is about doing a needs assessment to understand what drives current behavior and context and what would need to change to bring about the desired behavior. This is a cartoon of Professor Susan Mickey, who developed the behavior change wheel. This was from when we were giving a talk earlier this year, and they had someone live sketching her presentation when she was talking about this principle. So I think the real question here, as illustrated in this cartoon, is why would people change? What is actually driving behavior? Now, if we remember the starting point for this talk about clinical practice being a form of human behavior, we can use this principle to consider use of theories to help us address these questions. So we can use theories of behavior change that have been used to explain and predict human behavior in the general population to try to explain and predict the behavior of clinical practice. However, there are a lot of behavior change theories out there, about 83 across different disciplines. And the problem is all these different theories overlap. Some of them focus more on, for instance, motivation, whereas others might focus more on social influences. And no one theory was sufficiently comprehensive. So there's been lots of efforts within our disciplines to try to synthesize theories and bring them in together into one minimal set of coherent constructs. By that, I mean influences on behavior that are the minimum requirements for behavior change to occur. And I'm going to briefly introduce you to one effort, one model that aims to synthesize different behavior change theories into a minimal set of 3 necessary conditions for behavior, and that's the Combi model of behavior change. Now, Combi simply stands for capability, opportunity, and motivation. So the basic tenet of this model is that in order for behavior to occur, the individual or group of individuals whose behavior you're trying to change have to have the capability to change the behavior, the opportunity to change the behavior, and the motivation. They need to be ready, willing, and able to change the behavior. Now, we can break each of these down into further sub-concepts. So by capability, we mean the psychological and physical skills or ability to enact the behavior. So this is knowledge, the ability to remember to do the behavior, to pay attention, decision-making, physical and social skills to perform the behavior. By motivation, this means conscious and unconscious mechanisms that might be motivating us to perform this behavior and not perform another behavior. So these are things around how strongly I intend to do the behavior, my goals around the behavior, how relevant I think the behavior is to me, whether it's something I think I should be performing or it's not really relevant to me. What do I think will happen if I perform the behavior, or what do I think won't happen if I don't perform the behavior? How confident I am in performing the behavior, whether there's anything to reward or incentivize me to perform the behavior, or punish me or de-incentivize me if I perform the behavior or don't, and also emotional factors that might be driving the behavior, so anxiety, fear, or happiness. So those are operating at a more unconscious level. And lastly, opportunity can also be split into 2 subcategories. So physical opportunity to perform the behavior and social opportunity. So by this, we're talking about elements in the broader physical and social environment that can either facilitate or hinder the performance of the behavior. So in the physical environment, it might be things like access, resources, time, costs, things in the environment that might prompt me or cue me to do the behavior. And social environment are things like social support, social norms, any pressure, so more the social dynamic between individuals that can either, again, encourage a behavior to occur or discourage a behavior to occur. And a fundamental starting point for us when designing interventions is to try to use Combi to do a behavioral diagnosis. And we use a range of strategies to do this. So we often aim to ask questions to tap into each of these domains from capability, opportunity, and motivation to understand what role each of these factors play in facilitating or hindering the behavior of interest. So we might do interviews with the people whose behavior we're trying to change to ask questions around Combi, questionnaires. We might do observations to look at these factors, especially around opportunity, the environment. Or sometimes if we don't have time and resources to actually go collect data from the people of interest, we sometimes just sit there and discuss with key stakeholders or representatives from the group what we know about these different factors and consider them and how they might be playing and influencing the behavior. Now, Combi has been increasingly used in recent years to do a behavioral diagnosis of behaviors related to antimicrobial stewardship across a range of settings. And these are just a handful of studies that I put up as examples, which you might wish to read, that show the application of Combi to do really in-depth behavioral diagnoses with different stakeholders. So everything from looking at antibiotic prescribing in care homes, where they interviewed nurses, healthcare assistants, pharmacists, patients, and their relatives to try to understand the barriers and enablers of this Combi from the different perspectives. There's also been studies in older hospitalized patients, tertiary hospitals, dental practice, and even more recently looking at antimicrobial prescribing by veterinary surgeons. So it's increasingly being used to do this really in-depth behavioral diagnosis to try to address that gap in the literature around what are the behavioral factors driving antimicrobial stewardship. And these are some examples of some of the questions that some of these studies asked to try to tap into capability, opportunity, and motivation. So, for example, to tap into capability, we might ask around, what is your understanding of antimicrobial resistance and what antibiotics can and cannot treat? Awareness of the content of guidelines or even the existence of guidelines for antibiotic prescribing nationally or locally within a hospital, for instance, procedures for diagnosing and treating infections. And then for motivation, what do we think would happen if you prescribed an antibiotic or didn't prescribe an antibiotic? Will prescribing of antibiotics in hospitals actually make a difference to AMR? What are any concerns or emotions around the threat of AMR or the consequences of not prescribing? Is promoting antimicrobial stewardship something that healthcare professionals consider as part of their role, or actually is that a really small part of their role that they're not motivated to perform? What are the competing priorities and the incentives to use antibiotics less, etc.? And to tap into opportunity, we might ask around things such as team working dynamics, communication, availability of diagnostic tests, different types of antibiotics, the time, cost around engaging in stewardship or of using alternatives to antibiotic prescribing, and in terms of social influences, as well as team working dynamics, what influence do patients and relatives or other healthcare professionals have on your antibiotic prescribing practice? So I'm just going to give you a flavor of some of the findings from the behavioral diagnoses of these previous studies around each of these domains of Combi. So for instance, around capability, we actually find in the literature that there's a pretty good awareness of AMR and the global public health threat that poses. So it's not that clinicians are not aware of AMR, but rather there's other gaps around education and capability and skills that might be contributing to inappropriate antimicrobial use. So for instance, poor clinical microbiology knowledge or incorrectly adjusting certain doses for certain medications, not being aware of one's own antimicrobial prescribing practice, how appropriate is or not. So knowing that in general it's not appropriate, but what about my own specific practice? What the threat of AMR is locally, and what are the targets for more appropriate antimicrobial use locally? Guidelines, variable knowledge around guidelines. Some are very familiar with them, others not, and the lack of guidelines that are sometimes specific to the patient group or care setting. This is particularly in care homes that comes up, or in older adults or patients with comorbidities where perhaps there's not always clear signs for diagnosing infection, which leads to uncertainty around diagnosis. So there are some knowledge gaps and skill gaps around capability. Motivation comes up as a real big factor driving antimicrobial prescribing, and it's emotional factors that come up top in almost every study. So the fear or anxiety of missing something and causing potential harm to patient if an antibiotic is not prescribed. It's often seen that it's safer to prescribe an antibiotic than risk missing something and harm occurring. There's mixed views reported in the literature as to whether one considers whether one's own practice of the use of antibiotics will actually make a difference to AMR. So aware of AMR, but actually does my own practice contribute to that? And if I improve my practice, will it actually make a difference or not? Mixed views around that. As unsurprisingly, antimicrobial stewardship is often just one small piece of the puzzle and lots of different clinical issues to prioritize. And sometimes antimicrobial stewardship is just not that high on the list, so not that motivated. And sometimes clinical judgment and expertise and confidence around that overrides guidelines. So that's what's informing practice, the confidence around one's own clinical experience rather than adhering to guidelines. Or the views that alternative treatments or local measures to remove the source of infection sometimes won't work or will sometimes make things worse. So actually the belief that prescribing an antibiotic is better than the alternative. And lastly, moving on to opportunities. So in the physical environment, unsurprisingly, things like lack of time, lack of staff, lack of resources consistently comes up in all areas of healthcare as barriers to changing practice, but also in antimicrobial stewardship. So, there's lots of competing priority and resource constraints, which means that responsibility for and communication around antimicrobial decision making often becomes diffuse and uncoordinated. So it's, again, one piece of a bigger puzzle. Lack of diagnostics comes up a lot across different care settings. So lack of access to diagnostics and timely results means that we often find that clinicians prescribe without always having the information to make an informed decision. And also, given the high lack of time and high pressurized environment, there's often not a culture of quality improvement. And that starts to move into the notion of the social opportunity and social environment, which is a really strong driver of antimicrobial stewardship behaviors. So there's been some excellent research around that documented in that the rich issue of prescribing etiquette and prescribing hierarchies. So, these norms and practice, so unwritten social rules that people abide by. So not challenging a colleague's practice or mirroring a colleague's practice, especially the hierarchies between more junior clinicians and more senior clinicians, means that these social norms override policy and guidelines, and people more often adhere to them than actually the antimicrobial guidelines. Team working dynamics. So, for instance, nurses being a gatekeeper for diagnosing and escalating the potential issue and infection can sometimes be seen as a pressure by doctors and pharmacists. And there's also pressure from patients and families who often demand antibiotics and can sometimes result in doctors prescribing an antibiotic when they're not completely happy with that. And lastly, there's lots of instances where different roles, such as pharmacists, want to be more involved in antimicrobial stewardship, but don't feel empowered to, and there's often limited opportunities to meet as a team. So basically what I'm hoping to show here through all this is that there's a hugely varied range of factors influencing antimicrobial prescribing. This is just a very small snapshot of some of the things that come up around capability, opportunity, and motivation. The literature actually highlights a much broader range of barriers and enablers within each of these. So how can we use this really rich and in-depth behavioral diagnosis to move on to design an intervention? Well, if there's no single influence on antimicrobial prescribing, as we've seen, it's a complex behavior influenced by an equally complex combination of factors beyond knowledge deficits, then our starting point should be considering the full range of potential intervention strategies beyond just education. Education and knowledge, again, play a crucial role, but actually, as we've seen just now, there's a lot more varied issues there that education alone won't tackle. So we should consider the broad range of strategies and match the choice of strategy to the behavioral diagnosis. Again, I keep coming back to this key principle because it's really fundamental to behavioral intervention design in our discipline. Now, doing this, considering the broad range of strategies and matching it to your behavioral diagnosis, is again facilitated by using a framework. We in behavioral science absolutely love frameworks, not because they're psychologists that love boxes and arrows, but because actually frameworks make life easier. They can help simplify complexity and also standardize and increase communication and transparency in the intervention design process. So ideally what we would need to move on to intervention design is a framework that first of all outlines and defines a variety of options of interventions out there, and that can link the types of interventions to the theory of behavior change that we use to do our behavioral diagnosis. Now, we did a review of different frameworks out there that outline the different types of behavior change strategies available. And there's lots of frameworks out there. There's 19 different frameworks of different types of behavior change interventions from different disciplines. And a bit like what I said earlier about theory, the limitations in some of these frameworks is that no single framework was comprehensive on its own. So some focus more, again, on interventions to change attitudes, interventions to change the social environment, but none included all of the different strategies that were covered by other frameworks. And none of them were linked to a model of behavior change to, again, facilitate that all-important linkage of your behavioral diagnosis to selecting an intervention strategy. So quite simply, again, we synthesized. We integrated all those 19 frameworks to arrive at a coherent, theory-based framework of different types of intervention. Now, this is the behavior change wheel. This is the result of that synthesis. At its core, in green, as you will see, is the Combi model of behavior change. So it's the framework is rooted in behavioral theory. Around the perimeter in red are 9 different types of intervention functions, which quite simply represent broad categories or means by which an intervention can change behavior. So this includes everything such as our beloved education, so increasing knowledge or understanding, and also more indirect types of intervention strategies, such as changing the physical or social environment to encourage behavior change. So this is things like, I'm sure most people have heard of nudge, so that's changing the environment to try to encourage behavior change at an unconscious level. So a classic example of this is putting healthier fruits and vegetable snacks at your eye level and putting chocolates and sweets at a lower level, so you're not immediately seeing them and are perhaps encouraged to select a healthier food. Although, of course, we know that if you go to a supermarket, they now often put chocolate right by the cash points when you're paying to try to nudge you to buy them. So changing the environment can work positively or negatively to encourage behavior. But then there's lots of other options as well. I'm not going to go through all these, but very quickly, you can change behavior by trying to persuade someone using communication to induce positive or negative feelings to stimulate action by giving them incentives, punishing them, training them, enabling them, so creating opportunities to engage in the environment, modeling or demonstrating the behavior, or restricting their opportunities to engage in the behavior. Interventions can have more than one function, so a slightly different context, but I think is a good example to illustrate this principle. So here's a poster to try to discourage smoking in pregnancy. It's doing lots of different things. It's educating you about the consequences of smoking in pregnancy, but it's also persuading you by using visual imagery to communicate this issue and induce negative feelings that might stimulate action. But it's not just educating you and persuading you that this is a problem, it's also enabling you to change by giving you the telephone number and contact details of a stop smoking service. So it's reducing barriers beyond education, so it's encouraging you to actually do something. Now, intervention functions are quite broad. Education, enabling, restricting, yes, but how do you actually do that? So intervention functions are made up of smaller behavior change techniques. So if we think of the function as the cake, the techniques are the ingredients, so the eggs, the flour, the sugar that makes up the cake. So things like goal setting, action planning, monitoring your own behavior, giving financial incentives or social reward, feedback on the behavior, demonstrating the behavior. These are all smaller behavior change techniques that make up the different intervention functions. I'm not going to go into it in detail, but we have another framework, which is the taxonomy of behavior change techniques that was developed in our discipline, that simply synthesizes and describes the different techniques that have been used to date in the behavior change intervention literature. And there's 93 different behavior change techniques grouped into the different ways they might work to change behavior, such as shaping knowledge, incentivizing. So grouped almost according to the different intervention functions. So, and the taxonomy defines each behavior change technique, gives it a precise label and an example of how to operationalize or deliver that technique. And again, just like interventions have multiple functions, interventions often have multiple techniques. Now, crucially, there are 8 intervention functions, 93 different behavior change techniques. How do we pick, and are different functions and techniques more or less relevant to addressing different types of barriers and enablers? Well, unsurprisingly, yes. And it's really important to ensure there's a coherence between your intervention components and the diagnosis you've done. So for instance, let's take the technique, the function training and the technique behavioral practice rehearsal. Let's say you wanted to train me to shoot basketball hoops. And this type of intervention is only going to work where there is a lack of skill in performing the behavior, which there is. So I'm not great at shooting basketball hoops. So if that's the barrier, then yes, training me to do this by repeating the behavior multiple times is going to increase my skill and increase my capability. But this strategy will not work if I am not motivated to perform the behavior in the first place, or if I don't have the opportunity to perform the behavior in the first place, such as lack of access to a gym. So really important that you match the two. And this is, again, facilitated by using these frameworks I've introduced so far, because actually they have been mapped against one another. So here's, for example, the different intervention functions that are more or less relevant and effective in addressing barriers and enablers within capability, opportunity, and motivation. So, for instance, you can increase capability by educating and training using those intervention functions to build knowledge and skills. You can increase motivation by using persuasion, incentives, coercion, or modeling the behavior. And you can increase opportunity by changing something in the physical or social environment and using restrictive functions or environmental restructuring functions or social support through enablement. Now, we have, again, tools that aim to facilitate this linkage and guide this linkage. So, for example, this is a matrix that quite simply shows, based on evidence and expert consensus in behavior change, that shows the cells in blue show a match between the barrier and enabler within Combi and the different intervention functions. And there are also matrices that say if you've chosen a certain intervention function, here are different behavior change techniques you might consider. However, these only take you so far. As you can see, this is a long list of potential techniques and multiple functions you will consider. So we often say work through these steps and then convene a small meeting or panel with the key stakeholders of who you're trying to change and work through these different options and think about them against what we call the appease criteria. What's affordable to do in my context? What's likely to be practical? Well, is there any evidence in the broader literature that that intervention has worked before? Is it likely to be acceptable to whose behavior I'm trying to change? And are there any side effects or safety and equity issues I need to consider? So always consider the local context when picking the type of intervention strategy. Very quickly, because I'm almost out of time, I just want to briefly show you an example of how you can move from that behavioral diagnosis and antimicrobial stewardship I mentioned earlier to selecting an intervention strategy. And a lot of those studies that I showed you examples of earlier actually have tables in their papers that show this process step by step. So they have the dimension of Combi that they're trying to change, and then they mention the behavior change technique functions and an example intervention that would show that intervention strategy happening in practice. And what this aims to do is avoid the black box effect, but actually open it up and show a transparent, systematic, stepwise approach to intervention design. So, for example, in the tertiary hospital settings, poor microbiology knowledge and incorrect dose adjustment for vancomycin were shown as a key barrier. This is an issue around capability. So the functions here you would consider are education and perhaps environmental restructuring. And the example they gave here was using a pharmacist instead to do the dose adjustment, develop specialty-specific guidelines to clarify the indications for certain antimicrobials, and increase undergraduate and CPD, continuing professional development training. I think this is a really nice example around motivation. So in the care home context, for instance, being unaware of one's own antimicrobial prescribing practices, local AMR targets, rates of AMR locally, and targets for appropriate antibiotic use in that context, they suggested using a persuasive and enabling intervention whereby they did audit and feedback. So they set targets for antibiotic use locally based on guidelines, monitored practice locally to give care homes feedback on what current prescribing is in the care home, AMR rates locally to try to persuade them that actually it is an issue in your care home and there is something you can do by outlining deviations from guidelines and setting targets and recommendations for change. Fiscal opportunity. So in terms of fiscal opportunity, contacting infectious diseases was shown not to be straightforward, and it was often time-consuming to get approvals when prescribing from infectious diseases registrars. So they suggested restructuring the environment by adding web decision-based support and automated approval. So this is an example of restructuring the physical environment. But similarly, let's take the social environment and that prescribing etiquette issue. This is a nice finding in terms of getting senior staff buy-in, so not just targeting junior staff, but actually involving more senior doctors, getting them to model and demonstrate the behavior of interest, in this case, endorsing guidelines around antimicrobial use and adhering to them. So encouraging consultants to identify as a role model, as a credible source to encourage practice. And this has been shown to be very effective in, for instance, improving hand hygiene. And lastly, before I summarize, I just want to also, I know I said don't, just because it worked elsewhere, don't necessarily generalize it to your context, but there is actually a hugely broad wealth of literature on behavior change and quality improvement beyond AMR. And some of the issues we face with antimicrobial stewardship are not unique to antimicrobial stewardship. So for instance, audit and feedback, which was one of the interventions I just described to try to increase motivation, is one of the most widely used quality improvement interventions across different areas of healthcare. And there's a huge evidence base that's continuously growing to show how we can design more effective audit and feedback. So, for instance, if you deliver it more than once, It's delivered by a respected peer and colleague rather than an external source or regulator. If you give not just feedback, but recommendations and action plans to change, use multiple comparators, etc. So look beyond AMR to the broader behavior change literature. So just to quickly summarize, I hope today what I've managed to show is that behavior change is absolutely key to tackling antimicrobial resistance. And it is a complex behavior, antimicrobial stewardship, multiple behaviors with multiple influences. Yet we are often not considering these multiple influences on behavior when designing antimicrobial stewardship interventions, which means we have lots of unanswered questions in the literature. If I can leave you with one key suggestion today, is to try to avoid the Isliziak principle of intervention design and rushing to intervention without a specific rationale for your choice of intervention strategy. Instead, it's absolutely crucial to invest in more systematic intervention design. It's more likely to be effective and be a better use of quality improvement resources. So be specific about what you want to change and invest in understanding your behavior and context first. Do a behavioral diagnosis and use it as a basis to inform your selection of intervention strategies. There's lots of frameworks in behavioral science that can help facilitate this process, but ultimately I think it's about asking yourself these questions and trying to answer them and document them. So what are you trying to change? What's driving behavior and what will it take to bring about change? And how can I pick an intervention strategy that is relevant and coherent to that area? We are doing this in lots of different studies. I'll put the slide back up if you want to follow them. We're currently going through this whole behavior change wheel approach to design interventions, including for secondary care and hospital antimicrobial stewardship. So watch this space. And thank you very much for listening.
Great. Thank you so much, Dr. Lorencatto. You've left us with a very practical approach to undertaking the behavioral change process within an AMS program. That being, again, the behavioral change wheel approach, which, as you mentioned, can be applied with the help of numerous tools, such as the Combi behavioral diagnosis system, the APPEASE criteria to help with local contextualization, and the intervention mapping tool, just to summarize a few. In your presentation, I think what stands out to me as perhaps one of the most important starting points is having a systems way of thinking, as opposed to assuming issues in behavior are solely a sign of lack of competence or compliance. When you say that, so at this point, we'll open the floor to questions. As a reminder, you can use the chat function by typing in your questions into the question box in the control panel, or use the raise hand function. We welcome questions, comments, and your reflections along with your name and affiliation. To start, we have the following question, which is, are there any other approaches to undertaking a behavioral change process within AMS programs that are currently in use? And now I know, Dr. Lorencatto, you mentioned that there are numerous different other approaches that can be used, but which ones are being used, I guess, in practice, and how do they compare with the behavioral wheel approach?
Yes, absolutely. As just to emphasize, the behavior change wheel is one of many different frameworks for intervention development, and there's lots of others out there, such as intervention mapping, or you might have heard of BEAST from the Behavioural Insights team here in the UK government, all of which have been applied to antimicrobial stewardship. I think it's an area that's gaining traction, and the recognition of behavioural change and the need to more systematically design interventions means these different frameworks are being used, as well as perhaps just using more social science methods, so going in and doing in-depth exploration without necessarily using Combi. I don't want to get into a whole comparison of why one framework is better than another. I think ultimately my recommendation would be to just use any framework or any theory, and being explicit about that and transparent will ultimately help address some of the limitations around the lack of framework and theoretical use in the discipline. I think what's good about the behavior change wheel that perhaps other frameworks don't necessarily address is that it links to a model of behavior. So some frameworks just list lots of different intervention options without linking it back to the behavioral diagnosis element. So some of them go straight to the intervention stage without understanding the behavior first. And also, as I mentioned earlier when describing the behavior change wheel, it's a synthesis of all these different frameworks out there. So it's more comprehensive. So whereas some might focus more on nudge or environmental restructuring, the behavior change wheel aims to look at a broader range of intervention functions.
Okay, great. Thank you for that. So we have another question here, and I think you may have, I think you've covered this
in some depth. So perhaps you could summarize. But one question is how does culture of an organization affect behavioral change, the behavioral change process?
I think culture is absolutely key. Behavior does not occur in a vacuum, so it's really important to understand the culture that is driving behavior. So understand the social dynamics in which you're trying to embed the intervention is absolutely key. So as we've seen in antimicrobial stewardship, culture is a real barrier to change. If there's not a quality improvement culture, if people don't buy into it, if they don't see it as part of their role, or these ingrained prescribing patterns and habits sometimes override, for instance, guidelines we might be trying to implement. So understanding that you are going to be implementing an intervention in a broader culture and seeing who you need to get buy-in from to help implement that. So as I said, sometimes it's about getting senior consultants and getting the buy-in from the specialty or ward you are trying to change behavior in to demonstrate that this is something that is relevant and important. So I think, again, it goes back to being specific about who behavior change, understanding culture within that specific dynamic and involving them in the process and getting their buy-in and modeling and demonstrating the behavior is really.
Building on that, we have another question here, which is, could you comment on the use of academic detailing and social marketing techniques, such as those used by the pharma industry to influence prescribing practices? And this comes from one of our members, Kylie McIntosh from Safer Care Victoria in Australia.
There's evidence that they are effective. I think they will only be effective if I think it comes back to those strategies. Great, there is evidence that they are effective, but I wouldn't rush to using them unless there was evidence, for instance, that it was motivation and persuasion that needed to be changed. And there is something that signal in the literature that actually marketing falls within the communication and persuasive functions of the behavior change wheel. So it would be an effective choice of strategy if the main barriers were around motivation and needing to persuade around that. And academic detailing similarly as well. It falls within increasing education and training and enablement. So I think there's signals that those are appropriate strategies, that I wouldn't just rush to using them without seeing whether those are barriers in your specific context, because the starting point is always slightly different.
Okay, so thank you so much for that. Since we are approaching the end of our session, we would like to just take this opportunity to invite any last points that you'd like to make, Dr. Lorencatto, or any advice that you'd have for our audience.
I think sort of as I summarize, it's really key that we don't rush to intervention and we recognize the complexity of the behaviors around antimicrobial stewardship and invest in understanding behavior first to guide decision making when it comes to intervention design. Yes, it might take more resources and time, but I would argue that time and resources both spent if it's likely to lead to a more effective intervention that's more readily to implement. And I haven't had time to cover it today, but you can also apply this approach to optimize and refine existing interventions that have already been implemented in place rather than designing interventions from scratch, which is what I described today. And in this paper here by myself and my colleagues, we do give an example of that being applied as well. So I'd recommend reading that if that's of interest. But I wanted to say thank you once more for inviting me to come speak today.
Thank you, Dr. Lorencatto, for imparting your insights with us today. And thank you again to our audience, Kylie and Kantaj, for your questions. For any of the questions that we weren't able to address, please feel free to just send them our way via lhsn@imperial.ac.uk, and we'll do our best to have your questions answered. So as a reminder, the recording of this webinar will be available on our website at www.healthsystemsnetwork.org. New webinar announcements are posted on the LHSN social media account, so please feel free to follow us on LinkedIn, Twitter, and YouTube for that information, or sign up for the LHSN newsletter on our webpage. Now, for those of you interested in the latest OECD report on AMR, which was just released 2 weeks ago, you can register now for our webinar taking place next month on Tuesday, the 11th of December. Our speakers will present on best buys for AMR, interventions that are affordable, feasible, and cost-effective in the human health sector. Currently, their country-specific results stand as the most comprehensive and detailed assessments of AMR health and economic effects that have been undertaken. So we are expecting some excellent insight from that session as well.
especially to guide countries in their policymaking process. Now, to just wrap up, I'd like to highlight some of the network's latest works. On the 13th of November, earlier this month, LHSN released its report on antimicrobial stewardship, which presents an evidence-based and globally applicable tool, the checklist for hospital antimicrobial stewardship programming called CHAP. So we do invite you to take a look at that report by visiting our Comparative Health Systems Insight through an in-depth look at the checklist responses from 12 LHSN institutions across our LHSN network. So links can be found again on our webpage and also on the LHSN webinar email reminders. With that, we'll leave you with a very special thanks for joining today, and we look forward to having you with us again on the 11th of December for our next event. Bye-bye.